Hello, everyone. A lot has happened in the last year, isn't it? We all have been affected by this deadly coronavirus. Still, I believe it's a bit mystery as to how and exactly the pathogenesis occurs with the disease. Because had we had known this, the treatment would have become very simplified. In this video, we'll talk about the pathophysiology. I'll correlate the pathophysiology to the basic lab parameters and definitely we'll talk about the cytokine storm. Because once we know this, we can understand the diagnosis and we can understand what drugs to use, when to use, and when should you actually monitor the lab parameters again and again. Let's start the video. Coronavirus, the SARS-CoV-2 with the family of Coronavirinae and the subfamily of the Coronavirinae in which we talk about the alpha, beta, gamma, and the delta. This actual coronavirus SARS-CoV-2 belongs to the beta family. In the beta family, this again is A, B, C, and D, which actually belong to this B subcategory. The timeline, the first case in India was reported in the 30th January, and India has never looked back, isn't it? I know it's a pun, but it's quite true. So what has happened is over the years is that the 11th of March is when the WHO has announced this as a pandemic, and then is when the WHO actually started looking into what is the basic origin of the disease. Remember, the SARS-CoV-2 has not been the first virus of this category. There have been a SARS-CoV-1, and therefore it is now called a SARS-CoV-2. SARS, as you understand, it's a severe acute respiratory distress syndrome and coronavirus 1. Now, this was having a reservoir of bat and the intermediate host was of civet cat. In 2013 also, MERS-CoV, the MERS is Middle East Respiratory Virus Syndrome, which has again a bad reservoir of bat, and the camel was thought to be the intermediate host. While in 2020, SARS-CoV-2 came the deadly virus, which again has a reservoir of bat, and pangolins is believed to be the intermediate host of this deadly virus. Transmission, you all know, it is from the droplet infection, it is by contact, it is by airborne, and these are the three main ways how this virus can transmit. Let's talk about the basic thing why we have understood this. It is pathogenesis. See, what happens when the patient gets infected with the SARS-CoV-2, the multiplication occurs mostly in the upper respiratory tract. But after multiplying here, it again goes to the lower respiratory tract and it starts infecting the ACE2 receptors, which is on the type 2 pneumocytes. So what I've done is I've drawn a simple diagram for you to make you understand there is a virus here entering this alveoli. Now in the alveoli, there are type 2 pneumocytes and type 1 pneumocytes. Now we will talk about the type 2 pneumocytes in the alveoli. For that, let's see the simplified diagram here. In this diagram, I've made you understand that this whole thing is an alveoli, and below the alveoli, this is a pulmonary capillary. Okay, it's a pulmonary capillary. What has happened is this is the SARS-CoV-2 virus, which is entering the type 2 pneumocytes via a receptor called as angiotensin convertase 2 receptor, ACE2. So once this virus enters this via the ACE2, this actually starts multiplying here and at the same time causes pyroptosis of this typical molecule here. Release of the entire virus occurs, and that is when the body immune system starts getting activated. You all know for any infection in the body, the first to respond is the innate immune system. In this case, there is definitely neutrophils, but not to forget the role of lymphocytes because it actually is a virus. You have an immune system that the basic cell responding here is actually lymphocytes, the CD4 and the CD8 T lymphocytes. So what happens here is all viruses are then picked up by this innate immune cells, and in that category, the first one is a macrophage. The macrophage, which will actually take up this virus, and in that attempt to destroy it, it starts releasing some cytokines, which is actually interleukin 1, 8, 6, and TNF alpha. Okay, now what happens? This whole cytokine here, it's starting to stimulate now the other cells. So what happened initially was the activation was initially of the macrophage. The lymphocytes has all reached into this alveoli so that they can destroy the virus, and the macrophage releasing huge number of cytokines here. The cytokine is then again multiplying and is activating and actually adhering huge number of other inflammatory cells here. In that category, please don't forget the neutrophils role. Well, neutrophil after getting activation, they not only destroy the endothelium, but they also are chemo attracted into the alveoli. But if you ask me, sir, what is more, lymphocytes or neutrophil? Let me first put it here. The main cell involved here is here inside it is the lymphocyte. So here there is neutrophil definitely, but there's huge number of lymphocytes to such an extent that lymphocytes move from the capillaries into the alveoli, and hence you expect lymphopenia in the blood, and you can say in a degree of relative neutrophilia. But what actually happens is the lymphopenia in the blood. Okay. Okay. What happens also is, because the endothelial cells has got damaged here, please remember the endothelial cells here, they've all got damaged here. Remember, whenever the endothelial cells have got damaged, there's a rule of hemodynamics which you have read as Workhorse triad. These all endothelial cells will start activating the clot activation. They'll start releasing VWF because they have been damaged, and the VWF will start causing the primary platelet plug, which will then start causing the secondary platelet plug formation. Our body has a simple rule. Because there's a clot activation occurring by the primary plug, a secondary plug, it will start causing also simultaneously will activate fibrinolysis. Now, this is when the story starts getting further and further degraded if the infection is still persisting. In those lucky people in whom the infection is by virus or very less load, this will not progress further. But in those people in which the virus has been with a huge load, the body immune system never ever stops fighting. Like we are a fighter in life, our body immune system are also the fighter in the life. So what happens? All the lymphocytes, all the macrophage releases huge number of cytokines, and they start activating everything possible to remove the virus here. At the same time, what happens? This whole inflammatory cells from the alveoli, they start releasing some cytokines, and they release protease and the neutrophil elastase, which will actually start damaging the entire type 1 and type 2 pneumocytes. Now, this is when the endothelial cells have got damaged here in the endothelium, and the type 1, type 2 pneumocytes have got damaged here. All the fluid and the fibrin starts coming out from the vessels into the alveoli. This huge fibrin deposition here, it starts also depositing into the alveoli here. Now, this fibrin deposition is actually called as hyaline. Now, this is when what starts initially is interstitial edema, and then what happens is the pulmonary edema. Initially, there is interstitial edema, and then what happens is the pulmonary edema. Now, you understand the damage of type 1, type 2 pneumocytes are damaged. Because of the damage of type 1 and type 2 pneumocytes, the type 1 pneumocyte starts causing hypoxemia, and type 2 pneumocyte starts causing what is called as the surfactant deficiency, causing more and more alveolar collapse. Finally, what are we seeing here? We are seeing a finding of ARDS-like finding. Yes, the acute respiratory distress syndrome. So what you get and understand from this image is the entire pathophysiology involved in this SARS-CoV-2 infection. The basic thing you should understand here is, number one, there is pyroptosis of the type 2 pneumocytes. Second, you should understand the macrophage is causing huge release of cytokines. Third, you should understand there is lymphopenia in the blood because lymphocytes have moved into the alveoli. The fourth thing you should understand is the endothelial activation or injury has started to activate the clot, and the clot will always activate fibrolysis as a defense mechanism so that the clot doesn't progress to huge extent. Finally, the entire thing is now culminating to form the ARDS-like finding. The ARDS-like finding. The patient can form ARDS, and this X-ray would look as a ground glass appearance because the fluid has entered into the alveoli. That is when you can do the scoring system, and you all know it is a corads up to from 0, it is done up to 25, depending upon what is the lower involvement and how much the lungs is actually getting involved. Finally, so we have ARDS-like finding. The patient can have shock, and shock-like collapse finally can lead to death also. Based on this, let's see what do you or what can you do to diagnose a disease. Think. So what you have here is you have a huge degree of inflammation. Think, how would you actually diagnose a patient who is having inflammation? Let's talk about this now. Now, our major cytokine responsible here was IL-6. IL-6 was also accompanied by IL-1 and TNF-alpha. But let's talk about our hero today, and our hero is IL-6. The IL-6, you all know, it's a systemic cytokine which will first stimulate the liver and which will release the acute phase reactants. The acute phase reactants are a group of proteins which are released when they are stimulated by the cytokines into the liver. So what are those? Not to forget, substance important, it is CRP. Yes, the C reactive protein. There is serum amyloid, which we don't measure usually in the laboratories. Fibrinogen, which increases to cause increase in ESR. So increase in ESR, and you also have the complements here. Other than that, there also are ferritin molecules, which again is an acute phase reactant. So if you talk about the inflammatory markers, I will tell you there are three of them. Number one, number two, there is ESR, and not to forget, there is definitely ferritin involved here. Let's talk about this one by one to understand what is the basic role in diagnosing the diseases. See, the first one, the first one is the C reactive protein. Well, this protein is actually derived from the liver, and the protein was initially diagnosed or initially detected to be actually the reacting with the capsule polysaccharide of the pneumococcus. Now, many students think that the only role of CRP is only it acts as an active reactant. No, it has major roles in the body, and the most important of them being the activation of complement system pathway. Apart from this, it also has a role of apoptosis, phagocytosis, nitric oxide release, and cytokine production. So the body will start always releasing CRP so that it can either try to fend off the infections. CRP value is usually in most of the labs, it is up to 7 is normal, but yes, we will see some labs having 5 as normal and some lab having 10 as normal. But one thing to understand is a CRP value of more than 100, please remember, a CRP value of more than 100 microgram per ml is really having a grave prognosis in these patients. Now also remember, more important than the acute, just a simple value of CRP is the rising values of CRP. So often you should do CRP after every 4 days of disease, but before that you should do that, first establish your baseline. First of all, what you do is please establish your baseline. For CRP, the very important thing is establish your baseline. That means you should do CRP on the day of diagnosis, at least on the 4th day of diagnosis. Then you should follow it on the 7th day, and then should follow it on the 14th day. The reason of this is this 4th day CRP will act as your baseline. Because once you have made the baseline of CRP, then because you see, CRP is not only increased in the inflammation, a major chronic conditions like diabetes, atherosclerosis, or any other case of chronicity can definitely have a high CRP. So if your CRP is suppose 17 or 20, it will never come down even when the patient has been treated of COVID-19. So make sure you establish your baseline value and then you look into the further patients as to how the CRP is increasing. But one more thing is a CRP value of more than 100 is definitely proving towards a grave prognosis. Second cytokine and what you can measure is interleukin 6. Some values have a normal value, some labs have a normal value of less than 7, and some of them have around 17 picogram per ml. Many students ask me, so because the most cytokine is interleukin 6, 1 and TNF alpha, why do we only measure interleukin 6? Well, because interleukin 6 is a lab parameter which is actually being done and it's quite available easily, so we do it. But yes, if you are in a higher center, you'd always ask the laboratory to give them the report of IL-1 also and TNF alpha also, which has been documented very well in many of the studies. But for ease of purpose and for quick estimation, we can do IL-6 estimation. IL-6 estimation is not a very reliable marker because IL-6 may be normal even with a high CRP. On the other side, the IL-6 may be high even with a normal CRP. So we don't depend a lot on IL-6 mainly because of its very low short half-life. It's just you can say 1 to 3 hours. So we can't rely on a lot number of IL-6 in the serum. So what next? Next what we're going to do is the ferritin. Our ferritin value normally is 50 to 300 microgram per ml. But the bigger thing is, so why ferritin? The ferritin is actually an active phase reactant. And remember, ferritin, please remember one thing, the ferritin, the basic role is it binds to iron. Now, why does binding to iron make it important? Because if the ferritin can bind to iron, the iron is not free. Because iron is not free, it will definitely reduce the reactive oxygen species. So the reactive oxygen species is reduced if a ferritin is actually higher. So what happens is the ferritin which will bind to iron will prevent the body to get damaged by the reactive oxygen species. That is how the ferritin was actually increased in most of the inflammations there. The role of ferritin in again a COVID-19 infection is to tell you what is the amount of inflammation going on in the body. But is it a good marker? It is, but not a very good marker. You can't compare this marker with CRP. Inflammation के लिए take the best marker as CRP because that is actually seen to be very correlating to the disease severity, not actually disease severity, but a cytokine severity. Now, based on all of these, what exactly can we do? Why are we doing this? We are all doing these 3 inflammatory markers to look for whether the patient can go into cytokine storm. So what is cytokine storm? See, what happens sometimes is a patient, all patients have immune regulation, right? In some of the patients, the immune regulation is a bit milder In some of them, it's quite severe depending upon the viral load. In some patient, the immune activation is so intense, it just overwhelms everything. And that is when the patient starts releasing huge amount of cytokines, maybe IL-1, maybe IL-6, maybe TNF-alpha. And how do you get to know this? You get to know this by your repeated estimation of the CRP during the disease course. So try always to understand the values of CRP, the value of ferritin, and not to forget the IL-6 values that you should be doing in the patients of COVID-19 infections, because you never know when the patient can go from the normal state to getting into a state of cytokine storm. So what happens there is, as the patients have more and more cytokine coming up, it completely overwhelms the disease infections. So what happens at that time is the cytokine starts activating huge inflammatory cells that keeps on damaging the alveoli, which I explained to you in the previous slide, and that is when the oxygen requirement starts increasing in the patient. Because of high oxygen requirement, what happens? The patient starts going into requirement of more and more oxygen and can move from the normal oxygen to the CPAP and may go to the ventilators also. But that is what is cytokine storm. It basically is an immune dysregulation characterized by perpetuated, that means very high activation of lymphocytes and macrophage. Huge amount of cytokines, overwhelming systemic inflammation, and that is causing high mortality. High mortality. That is actually the main reason why patients can have cytokine storm. Now, let's understand what is the basic role of the D-dimer here. Well, where have we talked about D-dimer? D-dimer is actually a fibrin degraded products, and it's a very good indicator of, as you say, a negative predictive. It has very high negative predictive value for a clot being formed in the body. That means if a clot has been formed, please understand one thing. If clot was formed and the clot was lysed, after lysis, you get what is called as D-dimer. Remember one thing. If a clot was formed and the clot was lysed by the fibrinolytic pathway, the clot was lysed by fibrinolytic pathway, by fibrinolysis was there, it will form definitely D-dimer. So D-dimer is basically an indicator of the clot activation. I told you very clearly why does a clot form? Because of the endothelial damage occurring around the alveolar capillaries. So that alveolar capillaries is causing the activation of clot, and the clot is getting lysed by the fibrinolysis pathway. That is how the patients have high D-dimer in the patients. The more the immune activation, the more the endothelial activation injury, and that is when the patient has more and more high amount of D-dimer. The problem with D-dimer is, please don't take D-dimer as a positive predictive value. D-dimer only has a negative predictive value. That means absence of D-dimer will indicate the patient doesn't have DIC. So presence of D-dimer may not say it has DIC, but yes, absence of D-dimer will tell you about DIC. But yes, it has been overused and misused as a marker of inflammation, which it is actually not. So don't take D-dimer as a way as to when to stop the anticoagulants, because yes, when you start D-dimer, when you start coagulants, anticoagulants, when the value is around more than 1000, okay? So you will see the values in the lab being changed. Some labs given a value, some gives the value of microgram per ml, and some given the value of nanogram per liter. So what happens if you see a value of 3 microgram per ml, or some labs which gives us a value, some labs which actually gives a value of 1000. See, this value is either microgram per ml or nanogram per ml. So a 1 microgram per ml will be equal to 1000 nanogram per ml. But usually labs don't do this because there are different way of measuring it. So some lab will measure in the microgram per ml, whereas some labs measure in the nanogram per ml. So when you start anticoagulants, when the value usually is above 1000 nanogram per ml or above 1 microgram per ml. Okay, so that is how you start in the anticoagulants. Mostly it is the low molecular weight heparins. Okay, now what happens is, you should not only rely on the D-dimer coming down when you should stop giving anticoagulants, because usually what happens, it takes usually very high amount of time for a D-dimer value to come down and become ultimately negative, because D-dimer once has increased will really take time to come back to the normal values. So don't depend on the D-dimer only to stop your anticoagulant, but yes, D-dimer is an important step to understand what is the coagulopathy occurring in the patients. What is the coagulopathy occurring in the patients? So what do we have now? So should you measure D-dimer? Yes, you should. But should it be the first line investigation? It shouldn't be. If it's a mild disease, you will never measure D-dimer. If the patient is going towards high severity, that means he has high fever, he is having more and more oxygen requirement, definitely do D-dimer and try to initiate the low molecular weight heparin, because you never know when the patient can actually go to the and can actually have huge amount of thrombosis occurring in the cases. Well, what are the other organs involved in this disease? Is it only the hematological setup? No, not at all. Yes, the patient also have involvement of infections. Why infection? Because you see, this patient, whenever there's inflammation will always drop down the immune system. You have read this in septic shock. When there's activation of IL-1, it can also simultaneously activate IL-10. Now, IL-10 becomes an anti-inflammatory molecule. A high amount of IL-10 will drop the immune system, and you should understand that a patient can have more and more overwhelming infection over a virus infections. So how should you rule it out? Try to rule out by doing this test called as the procalcitonin. A procal level, please remember one thing, a procal level of more than 0.5 is an indication that antibiotics should be started. But a procal level of less than 0.5, let's take it as a cutoff of 0.05, 0.5 microgram per liter. Less than that, do not give antibiotics, but more than that, try to initiate antibiotics because the patient may have a bacterial pneumonia also. So often we don't start bacterial pneumonia, say polymyxin B or peptides, when the patient is diagnosing with the COVID-19. But if you expect the fever not coming down, you expect the CT score getting more and more progressively higher, you expect the X-ray becoming more and more worse, that is when you expect the patient may have a bacterial pneumonia. You do a procal being high, you initiate the antibiotic therapies there also. About LDH. Now, LDH is a marker which is actually not directly of inflammation, but it's a marker or a molecule released. It's a marker or a molecule released whenever there's an alveolar damage. More the alveolar damage, more the amount of LDH. So clinicians have used LDH and they have correlated this LDH value to the more and more oxygen requirement. But is it directly an inflammatory marker? No, it is not. LDH is released when more and more alloy getting damaged, and that is how you find a more and more higher amount of LDH. Okay, you find a more and more higher amount of LDH. Apart from these all, the patients have also been shown to have myocarditis. You can see for myocarditis by looking for molecules like CK and CKMB. And if you're expecting a patient to having congestive cardiac failure, try to rule it out by looking for the BNP and the NT-proBNP. If a patient has congestive cardiac failure, you may also think about the myocardial infarction. To rule it out, try to do TROP-I and the TROP-T. So for looking for the carditis and the congestive cardiac failure, try to do these markers. It will give you a good idea whether the patient has any amount of myocarditis or is going toward the congestive cardiac failure in these patients. So can we have a good amount of conclusion here? So when a patient has a diagnosis of the COVID-19, what do? You start looking for lymphopenia here. He definitely has mild thrombocytopenia also. In the coagulopathies, he has high dimer values. He has increased CRP, increased ESR. Okay, these some indicators will also help you, but not a lot. But yes, some markers becomes a prognostic markers in this case. Not to forget, thrombocytopenia is a poor prognostic marker. Increased dimer and decreased fibrinogen again becomes a poor prognostic marker. Increased CRP more than 100 is an indicator of poor prognosis. A high procal level will also indicate a patient going towards bacterial sepsis and is actually an indicator of poor prognosis. Finally, what you should do in these patients? First of all, try to diagnose the disease as early as possible. To diagnose the disease, you first do a RT-PCR or a antigen testing. You all know the antigen testing or the RT-PCR, and how should we do that? The antigen of the RT-PCR is basically based upon detection of certain things. Like, you look here, for looking for the RNA, you do a real-time PCR. It can be a cartridge-based called a CBNAT, or it is a chip-based TrueNAT. But what we basically depend upon is the reverse transcriptase PCR. Okay, so real-time reverse transcriptase PCR. So RQ is real-time, RT is reverse transcriptase, and PCR you know is polymerase chain reaction. The basic targets that we should look into the RT-PCR is the open reading frame ORF1A and 1B, the S gene, the spike protein S gene, envelope gene, E gene, the neuraminidase gene, N gene, and the RDRP, which is the RNA dependent RNA polymerase gene. So these are basic targets we look into the RT-PCR. And one thing is very confusing in the I've seen the clinicians is look at the CT value. Please don't look at the CT value of the RT-PCR, with the CT score of the CT scan is quite different. CT score is done in the CT scan, and CT value is actually telling you the number of cycles when the reaction reaches the threshold value. What does it mean? See, it's very simple. Suppose the virus has 2 cycles of replication and it got amplified. And there's another virus which had 10 cycle of replication and then got amplified. The reason was, in the first case I gave you with 2 cycle of replication, that means the virus load was already high in the patient. So with even a less number of cycles, the virus was detected. But in a patient who has 10 cycle of replication and then getting detected, it means the viral load was low. So correlate CT value as high CT value as low virus load, and a low CT value as high virus loads. About antibody testing. We all know antibody being done, and especially with the availability of the vaccines nowadays, the 2 vaccines, the Covaxin and the Covishield, we should also rely on the antibody testing. Antibody of IgM is not done because not a very use, but yes, Ig is done, and that IgG is a good reliable marker where the patient has been exposed to the COVID-19 infection or has been vaccinated. That means whether he has immunity towards the infection or not. It's done by looking for either total antibody, or best to look is the IgG antibody against the SARS-CoV-2 infection. Many of the laboratories, they actually try to give you the value especially against the S protein, but most of the laboratories will give you just generalized IgG value. Now, if you ask me, sir, what is better? Sure, it is against the spike protein of the virus. That means IgG, especially against the spike protein, but doesn't matter. Any value of this is quite sufficient to give you a relative indication whether the patient is immune to the infection or not. The plasma therapy was actually given a lot of trials, but as you know, recently it has been removed from the therapeutic trials, and therefore we will not discuss this at all now. Okay, even though I made a video out of it and put in my own YouTube channel, you can watch it down to look for all the indications and the contraindications and how it is done about the conventional plasma therapies. Vaccines. You all know the 2 vaccines, that third vaccine being available now: Covaxin, Covishield, and Sputnik. So Sputnik actually has a 28 days of the second dose period. Covaxin has 28 days. Covishield has around 3 to 4 months, which is recently modified by the Indian government. And who knows what comes next. Finally, my final statement. What should you do about the COVID infection? First of all, try to understand the basic pathophysiology. Try to understand, because once you know the pathophysiology, you will be able to treat your patients well. Try to understand the basic lab parameters, and try to basically understand the lab parameters will give you good indication not only of the patient's condition right now, but will also tell you about the prognosis of these patients. Every marker has its own clinical significance. The more better you know it, the more better you will be able to understand and treat your patients in the best possible way. Treatment options, you know, there are not many, but yes, initially we just give a symptomatic treatment by oxygen therapy. When the patient gets more and more worse, you can give the remdesivir, which actually stops the RNA transcription and translations. Finally, you try to give the steroids to inhibit the inflammation going on. You give tocilizumab to actually block the IL-6 receptors, and there's not a lot of much you can do because plasma therapy has been now removed. So what to do is only and only symptomatic therapies. That is how I have tried to give you every gist what you must expect in the COVID-19 infection. I hope you like the video, and make sure you just watch this video once more and try to put all the important points in your notes. That is how you will entirely complete the 0 to 100 of COVID-19 infection, COVID cure. Thank you. With best wishes, do good in the exams and give the best to your patients. Bye-bye. Take care.